اللي ابتديناه من 3 سنين، وما زال بفضل الله سبحانه وتعالى وبتوفيقه سبحانه ثم بمشاركة أساتذتنا الأفاضل ما زال مستمر، وإن شاء الله بأمر الله يستمر بإذن الله تعالى. النهارده يوم مشهود، معانا 2 من أعلام ومن عمالقة الAO في الوطن العربي. النهارده معانا 2 أساتذة مشهود لهم بالعلم والخلق والأدب والأخلاق الحميدة. أنا سعيد جدا إن معانا 2 من القامات القيمة والقامة. أستاذنا دكتور سفيان بن قلال، Professor of Orthopedic Surgery والهيد of AO Chapter في تونس، وأستاذنا الحبيب أستاذ دكتور أسامة بيه فاروق، يعني رمز الأدب والأخلاق في مصر وجامعة أسيوط، وطبعا يعني عملاق الAO في مصر وفي العالم العربي. النهارده يوم جميل، احنا هنتكلم على الفراكتشرز around the knee. استاذنا الدكتور سفيان هيمتعنا بمحاضره من محاضراته الشيقه fractures of the distal femur، واستاذنا الدكتور اسامه بيه فاروق هيتكلم عن موضوع very interesting التيبيال بلاتو fractures. انا بيسعدني ان انا ارحب بكل اخواتنا الاعزاء الافاضل الحضور من مصر ومن ليبيا ومن الجزائر ومن تونس ومن التشيك ومن اي دوله عربيه او اجنبيه، كلهم مرحب بيهم اشد الترحيب. هنبدا ان شاء الله مع استاذنا الدكتور سفيان بن قلال. استاذنا الدكتور سفيان بيه will speak about fractures of the distal femur. بروفيسور سفيان.
اوكي سيدي، مرحبا بكم، وانا شكرا على هالاطناب هذايا في الثناء. والله انا ممنون جدا، يعني كل مره سواء كنا نلقى روحي في مصر والا نشارك في بنها، لانه توا الرابع مره يظهر لي نشارك في ليكتشرز نتاع كليه بنها بمصر، وكل الامتنان معناتها للدكتور الاشهب وزميلي واخي وصديقي الدكتور اسامه فاروق. أنا I will stick as كما قلت أنت as a lecturer as usual، يعني في to talk about the distal femur fractures and to explain what are the main things that we have to understand about distal femur fractures. First of all, I will try to describe the surgical anatomy of the distal femur and its influence on implant use. Which implant do we use, since we have panoplia of large type of osteosynthesis? To explain indirect reduction maneuvers, because it is very important. It is, I think, the fracture that need mostly or only indirect reduction maneuvers to reduce the fracture. Since it is difficult, I will show you how to reduce it. We will compare the indication and techniques for plating and nailing, how and why to choose a plate or a nail, and outline the management of complicating fractures. Osteoporosis mainly, it is the main complicating factor, since these fractures can happen mainly with old people, with severe comminution in young people, and finally about periprosthetic fractures. And to evaluate the key outcome of publication that we have on the literature till now. It's very important to understand the importance of the osseous anatomy of the distal femur for radiographic evaluation of fracture characteristics, for critical assessment of the reduction, how to reduce, and for deciding the optimal implant choice and positioning once you really understand your radiographic evaluation, which is very, very important in such type of fractures. Just to remind you, the anatomic landmarks of the distal end of the femur, which has a complex shape, because there is articular surface, there is lateral condyle, medial condyle which is larger, abductor tubercles, medial epicondyle, and the medial condyle. And it's very important to analyze the articular margins and the articular surface and the limit of the articular surface, since they are the key of the functional result of this type of fractures when you have to reduce anatomic reduction of the distal femur. The geometry of the distal femur of the end is trapezoidal and shape that determines positioning of the implant. You see different angles. Then when you put your plate, it should be exactly with this type of angles, and not to miss how to put your screws and to have perpendicular screws to the plate and not be in the notch or in the articular surface. Then the implant should not be penetrate the intercondylar fossa and should have a proper length. This is what may happen if you are very posterior. You will have your screw in the notch, and then it will interfere with the insertion of the ACL or the PCL. And sometimes it is not too easy. That's why we start in type C, for example, to reduce the fracture from type B to type C to type B. It means to reduce the metaphysis first, and then the metaphysis to the diaphysis. And then you should be aware about the positioning of the screws to not interfere with the plate. In AP radiographic views, an implant that is too long may appear correct. You see, like here, how the positioning of the screw, you have the distal femur, which is an external rotation, and on the X-ray, you will see exactly the same thing. And in the same time, the positioning of the plate was not correct. Then in the distal femur fracture, there is special biomechanics. What is conditioning this special biomechanics is the gastrocnemius muscles causes the posterior angulation of the distal fragment. Since there is traction on the distal fragment and you have the recurvatum of the articular surface, and it is very important to neutralize the effect of the gastrocnemius and soleus muscles complex, which are posterior. Then any traction with extended knee will increase the posterior angulation of the posterior ligament due to gastrocnemius anchorage. You see, when you track, then the distal femur here will go more posteriorly since this muscle will tract on it, and you will have an angulation, posterior angulation. That's why for the flexion, the positioning of flexion of the knee will eliminate the influence, or will limit, we say mainly limit. It's very difficult that it will eliminate the influence of gastrocnemius muscles, and it is very difficult to reduce these posterior traction. Then what type of traction that we have? To be manual, we may use an external fixed femoral distractor, external fixation, or fractional table. Then you have different options, but one aim is indirect reduction, and be aware about the osteoporotic bones when you do an indirect reduction to not make more damages in the zone where you will apply your traction and not to create another crack. Then the goals of indirect reduction is to maximize the preservation of the soft tissue. Then we will give more chance to this fracture to heal, to promote secondary bone healing, to minimize non-union and delayed non-union, and to obtain 3.3 keys are very important. Distal femur it's like for the femur, diaphyseal femur, it is the same thing for the distal femur. You have to reduce to restore the length, the alignment, and the rotation. And the rotation is the most important, since as I showed you, the anatomy of the distal femur is very particular, and you have different angles, and it is very important to restore these. Remember these 3 points: the length, the alignment, and the rotation. These are different technique, useful tricks how to reduce the distal femur. Then you can use a distractor, femoral distractor, like in this case. Then you will use another pin on the distal femur and try to reduce and to prevent posterior bending of the distal fragment. And you use a wire loop, like here, you use a wire loop here, and to maintain the reduction and to neutralize the effect of the gastrocnemius and the soleus. Then all the implant of the distal femur has angular stability. You see here the oldest one, which has the blade plate 95 degrees, DCS 95 degrees, DF and distal femoral nail, you have the angulation here, the LCP, and at the end you have the LIS and you have always an angulation in the distal part of the femur. Then you have different types. You have blade plate, DCS, nail, and list plate. And then for the nailing, intramedullary nailing of the distal femur is mainly for type B fracture in the classification of the distal femur. It is separation between the epiphysis and the diaphysis. In the partial part, I think there is no place for the nailing, since in that case you need a buttressing plate that's to compress this fragment unicondylar fracture. There is no place for the nail in such places. In type C1 and type C2, the main thing is the first step is to reduce the type C, to transform the fracture from type C to type B. Then first step is to reduce these two fragments, the epiphysis, and then you will have like a B fracture, and in such situation you can do a nailing. But it remains the type C mainly for plates. Then plates have wider spectrum of indication, mainly for closed fracture and even open fracture, and mainly for type C fractures. You can use DCS like this case, and it is angulated DCS at 95 degrees in such case. And these plates are more invasive. The intramedullary nailing is less invasive. There is smaller incision. It preserves soft tissue around the fracture. Percutaneous joint fixation in non-displaced articular fractures. Weight-sharing devices are less, and the device is more in line with the axis of the femur. These are the advantages of the intramedullary nailing, but the indications are a little bit limited. The disadvantages of intramedullary nailing are the limited space for nail insertion in articular fracture, patellofemoral joint, potential issue with proximal looking, question of increased knee infection with open fractures, and the bone union enrichment technique, and may have more difficulty with removal of an intra-articular device. Then the retrograde femoral nailing, the entry site problems. There is problem of how to approach, and the optimal site in line with the intramedullary canal may occasionally be collocated in the patellofemoral contact area due to anatomical variability. Then we have to avoid any contact between the patella and the entry point of the nail, and you should be exactly in the axis of the diaphysis of the femur. Unfortunately, the optimal site may cause displacement of the distal segment in some cases. On the other hand, for the plates, and can be used in different manners depending on the type of fracture, neutralization, compression fracture plates, or bridging plate, and with direct or indirect reduction technique. It's a little bit easier to be with the plate than with a nail. You have open technique and mini-invasive technique plate osteostentesis. We are more and more using mini-invasive technique. Why? To avoid more complication, to have more chance to have union and avoid malunion and malreduction. The plate problem sometimes is very difficult to control the positioning of the plate, since, as I explained to you, there are different angles for the femur, and to be exactly on the 25 degrees of angulation with the distal femur in the epiphyseal part, and to control in proximal to be exactly in the axis of the femur. Otherwise, you will be sometimes out like you see in the X-ray on the right side. Fixation in difficult situation when you have osteoporotic fractures, periprosthetic fractures, and we have comminution. These are cases where you have difficulty to have your osteosynthesis, which is a little bit rigid, to maintain the reduction of the fractures. And plates with locking hip screw make it possible. Even you have sometimes some prostheses which are above, but the LCP, LSH give you an opportunity to have with locking screws good fixation in the proximal part and the distal part. And in such situation, in difficult situation, retrograde nailing can augment fixation when medial comminution is present. The difficulty when you have a medial comminution in the medial part, medial comminution, there are shearing forces inverse, and then there is a risk of malunion and non-union. That's why adjusting a nail with the plate may give more rigidity to the internal column of the femur. It means more stable medial compartment. Then you have more chances to have a healing in a good position and avoid the malunion. I will give you some key publications about less invasive stabilization system. The LIST and Andramil offer enough torsional stability and effective proximal fixation to withstand axial loading. Additionally, LIST provides better distal fixation. It is important for osteoporotic bones. This is 2004, 2005, prospective randomized trial, level of evidence 2-3. And the two methods between nailing and plating, the two may have the same percentage of excellent result. Retrograde MI is preferable to DCS in terms of less blood loss, since it is much less invasive. Safer in 2003, 2004, there are low complication rate, and retrograde nailing is effective as plate osteosynthesis. 2008, still a little bit later. Then outcome, union rate, fixation failure, infection revision surgery, you have almost the same result. Like here, comparing retrograde and DC LCP plates, they are almost the same. And for periprosthetic fracture of the distal femur, it's a really particular situation. Why? I'll give you like a case. This is a lady who present to emergency department 1 month later, and total knee replacement with pain on the knee. And you see here the X-ray, they gave her only NSAID and would heal, no sign of infection, laboratory value normal. She came back after the X-ray. But you see here, the notching is positive, and this posterior displacement of the distal femur. And it was already started the fracture. And she came back 3 days later with patient hears and feels a crack during normal activity. Then you should be aware about any pain on the knee, which can occur just post-op in the early period, mainly if you have a notching in the superior part, to be aware about the risk of fracture of the distal femur and not let the patient arrive in such situation. You see there is a big comminution of the metaphysis, and the positioning where using inflection, as I told you, for a bump to neutralize the effect of the gastrocnemius and the soleus. And this is the trying to reduction, but it remains imperfect. And by mini-invasive techniques, because there is an arthroplasty in it, and we should be more and more mini-invasive to avoid any risk of infection. This is the positioning of the plate, but you see it is very difficult to control the prosthesis, since the indirect reduction is very difficult because you have the prosthesis, then it's very difficult to control the epiphysis. And you see here, you use a posterior retractor and the mallet, and you try to elevate the distal part to bring it up and to reduce the fracture. And then you fix your fracture here. And this is the final aspect and the final result. And you use an augment in the medial part. And this is the aspect in post-op. This is the aspect 3 months later, 1 year later, and 5 years later. It is very difficult. These fractures are really very, very difficult because, as I told you, the difficulty is mainly how to reduce and how to maintain the reduction by an indirect reduction, and to be more and more invasive in the distal part. This is the final result of this patient. Then distal femur replacement community fractures in elderly with osteoporotic bone. The advantages is immediate that when you have a very comminutive fracture of the distal femur in elderly patient with osteoporotic bone, the distal femur replacement, this right tumor prosthesis, could be an option. What are the advantages? Is immediate weight bearing, eliminate the risk of non-union, malunion fixation, failure, and post-traumatic osteoarthritis. Don't forget, this patient should walk as soon as possible. In elderly patient more than 75, you have to think how these patients will walk after surgery, because they are not able really to not weight bear after surgery. They don't have strong arms to use canes and walkers and so on. Then we have to give them the opportunity to walk as soon as possible. But the disadvantages are limited salvage option in cases of osteolysis, loosening, or periprosthetic fracture, or mainly infection. What are your take-home messages? To understanding the osseous anatomy of the distal femur is critical for successful fracture reduction and implant application. This is very important to have your plate in very good position. Indirect reduction technique should account for forces from gastrocnemius muscles. Then you have to fix your distal femur inflection using a balm and different devices to reduce the fracture and to neutralize the effect of gastrocnemius and the soleus. The fixation implant should have some form of angular stability as usual. Both the plate and nails have wide indication with reliable result when used correctly. Then don't use very comminutive fracture with the nail and you have non-angular stability. It is very important to understand the indication either for plating and nailing, or both, as I told you, in comminuted medial part of the femur to avoid risk of malunion. And in case of total knee replacement, indirect fracture reduction and submuscular plate fixation are effective techniques for distal femur in periprosthetic fracture of the distal femur. Avoiding disruption of medial soft tissue can lead to early callus formation and healing, even in the presence of the prosthesis. Thank you very much.
Thank you so much, Professor Sofiene, for this very interesting talk. شكرا جزيلا أستاذنا الكريم دكتور سفيان بيه.
مرحبا بكم.
We have two questions, sir.
If you are, we can take questions. Yes.
Yes, sir, please.
Then
First
we
question,
all
sir.
know that the stiffness of construct, the more incidence of non-union. How can we solve this problem? First of all, before thinking about the stiffness of the construct, we have to think of the type of the fractures, and the risk of non-union and the malunion are mainly for the medial part, the medial columns of the distal femur. Then this rigidity will give you the opportunity to have the primary callus, and once you will have the healing, the patient can start its partial weight bearing and to try to stimulate his callus. It is very difficult to find the compromise between stiffness and mobility in this type of fracture when we need relative stability, and that's why sometimes we use in the same time the nail and plate. How can we dynamize it distal? No, there is no dynamization in the distal femur place. Can we dynamize distal femoral plate? There is no possibility to dynamize. We are in a metaphyseal fracture, and the risk of the dynamization may lead to malunion. Brahim Kawar, how about your experiences with the nail in case of fractures with total knee? Yes, you can use, yes, some, but you should be aware to analyze the type of prosthesis you should be sure, because some prosthesis cannot give you the opportunity to put a nail.
Yes,
then
this is a very important question, sir.
It's very important. It's to know the procedures. Once you receive a patient, you know before going to the OR, know what type of prosthesis he has done. Go and see the documents of the prosthesis if it gives you the opportunity, but it can be a very good opportunity. The nail in distal femur fractures on a prosthesis. دكتور مصطفى مرحبا بك من بنغازي. How to deal with morbid obesity, diabetic and osteoporotic associated distal femur fracture? Very interesting question. Thank you, Dr. Mustafa. Then it's a challenging obesity, diabetic and osteoporotic. You brought all these problems in the same patients. It's very difficult. Nail could be less invasive. My advice, it be less invasive as you can. Prepare different type of indirect reduction. And I know that the femoral distractor is not available in all the OR, but I do suppose in Benghazi you may have it, or use a distractor, femoral external fixation to reduce, and use the device that I showed you to open less and less and less, and use the aimer of the distal wrist plate to put your plate and screws without opening. Dr. Muhammad Khalid, in case of association of fracture with ligamentous injury such ACL or MCL injury, it is recommended to do alignment reconstruction with fixation or to delay it after union. No. ACL, MCL, there is orthopedic treatment. There is no surgery for MCL in the emergency. ACL would be delayed after treating the fracture, and we see, but it depends on the patient. And most of these fractures occur in elderly people. In case of young guy, you will delay it after healing the bone. Sigma, it's open. Yes, Sigma of J&J give you the opportunity to put a nail. Yes, Sigma is open, but there are other prostheses which are not open, and you cannot use a nail on the prosthesis. Dr. Sharif Nagar, what precautions to avoid mechanical failure? To avoid mechanical failure, you have to understand the fracture. That's what I explained in the beginning. You have to have a good construct, and the big problem is when you have, as I told you, very big comminution in the medial part above the medial condyle. You can associate a nail to a plate to have more rigid construct and to avoid malunion. Brahim Kaur, we can make a graft in a complex fracture. Yes, we can graft. We can put cement and go back in open fractures and to put flap. Osteotomy, doctor, osteotomy around the knee. Hi, doctor, osteotomy around the knee, floating knee, distal femur, and proximal tibia. We will prepare a new talk with Dr. Osama, and we will talk in the same times about distal femur and proximal tibia. Now, we will, floating knee is very interesting question. You will start with the most complicated fracture. You will combine the approaches, but we are more and more mini-invasive. Try to find the solution to be the less invasive that you can. Distraction with a femoral distractor, good positioning, and direct reduction will give you the opportunity to reduce a big amount of fractures before putting your plate. Then you analyze your anatomy and to start to fix what is well reduced, and the strongest part, and then the weakest part. Then, is it mandatory to put medial plate? No, Dr. Muhammad Abdelal, it is not mandatory for medial plate. Less you are invasive, if you are not very invasive, I explained that in the talk, you will have a healing of the medial compartment. What about rheumatoid patients? You will treat as the others. There is no special precaution about rheumatoid patients. غسان بوعوجة مرحبا بيك سي غسان. What do you think of the MIPO technique for community fraction? Yes, it's a good, but community fraction metaphysical part. Articular surface, you have to see your fracture to control the reduction, transform the type C in type B, and then you will put your plate.
شكرا جزيلا دكتور سفيان بيه. احنا يعني تعبنا حضرتك في الاسئله
مرحبا بكم.
وهي بصراحه كلها interesting questions يا استاذنا.
And very interesting. I'm here to answer all the questions اللي عبالكم. مرحبا بهم.
Thank you so much sir.
مرحبا بكم.
دائما مرحب بحضرتك يا استاذنا معانا، يعني شرف كبير لنا دكتور سفيان بيه.
أسامة نشوفك بخير عن قريب ان شاء الله.
الله يخليك يا دكتور سفيان، شكرا جزيلا استاذنا. شكرا جزيلا.
ان شاء الله يا دكتور سفيان نلتقي على خير باذن الله، ومحاضره رائعه استمتعنا بيها. بارك الله فيكم.
شكرا شكرا شكرا.
شكرا جزيلا دكتور سفيان بيه. دلوقتي ميعادنا مع المحاضره الثانيه، استاذنا الفاضل المحترم الغالي استاذ دكتور اسامه بيه فاروق، جامعه اسيوط ايجيبت. استاذ دكتور اسامه بيه فاروق طبعا من اعلام الاي او في مصر وفي العالم العربي كله. يا فندم.
يا فندم العفو، ده يعني من كرم حضرتك.
عفوا دكتور اسامه بيه.
بسم الله الرحمن الرحيم. يعني اولا انا بشكر الاستاذ الدكتور محمد الاشهب، الاخ الفاضل العزيز، استاذ جراحه العظام وعميد كليه الطب جامعه بنها، لدعوتي ان اكون معاكم الليله في هذا اللقاء العلمي الرائع. I would like to thank my dear friend and brother Professor Muhammad Al-Ashhab, Professor of Orthopedic Surgery and Dean Faculty of Medicine, Banha University, for inviting me to join you in this meeting. يعني أرجو أن ربنا سبحانه وتعالى يجعلني عند حسن الظن بعد المقدمة الرائعة من الأستاذ الدكتور محمد الأشهب. Now we are going to talk about the tibial plateau fractures, and we are going to talk about the updates and the current situation and what happened during the last decade regarding the understanding of tibial plateau fractures. So we are going to talk about the soft tissue consideration in tibial plateau fractures and how it is now one of the important issues when we assess tibial plateau fractures. We are going to go through the classifications of tibial plateau fractures, the classic classifications and the current new classifications, and we are going to talk about how can we plan for our open reduction and internal fixation. How can we make a decision about the surgical approach or surgical approaches of the same case? And lastly, an update about the fixation techniques nowadays. First of all, we all think about the spectrum of injury when we receive a case of tibial plateau fracture, and are not all the same. We have high energy trauma and low energy trauma. When we talk about the high energy trauma, we are concerned about the associated soft tissue injury. These injuries usually occur in young aged patients, and the problem is usually biological about the soft tissue trauma, the blood supply. And another type, which is low energy trauma, where the soft tissue injury is minimal, usually occurring in older patients. And the problem here is a fixation problem. The bone is osteoporotic. What about the principles for soft tissue management in high energy trauma? We have here some issues to consider about the associated soft tissue injury. Whether it is an open fracture, we have a wound, or a closed soft tissue injury. We have to assess if we have associated vascular injury. This is an emergency, or a compartment syndrome, another emergency. For all these fractures, we will apply a spanning external fixator and deal with the vascular injury or the compartment syndrome or the wound. It is better to have a staged approach than to have an infected fracture. Another issue regarding the soft tissue injury, the associated soft tissue injury, is the associated meniscal and ligamentous injuries, or the internal derangement of the knee joint. And we will come across this issue as well. Can we predict the compartment syndrome from the plain X-ray? We all agree that compartment syndrome diagnosis is a clinical one, and we expect, or we are concerned about compartment syndrome in all proximal tibial fractures, including displaced tibial plateau fractures. The overall rate of compartment syndrome associated with tibial plateau fractures is 11%, as figured out in this study published in the Journal of Orthopedic Trauma 2013. And when they analyzed the radiographic predictors of compartment syndrome in tibial plateau fractures, they found both tibial widening and femoral displacement to be significant with respect of the development of compartment syndrome. These are the two radiographic predictors of compartment syndrome: the tibial widening, when we measure the width of the distal femur and compare it to the width of the fractured tibial plateau, we find this amount of tibial plateau widening. And again, when we look for the femoral displacement ratio, we can measure the displacement of the tibial anatomic axis relative to the femoral anatomic axis. These are two radiographic predictors of compartment syndrome, but we should suspect compartment syndrome in each tibial plateau and in each proximal tibial fracture. Again, what about the incidence of soft tissue injury? As we highlighted before, we mean here by soft tissue injury the associated meniscal and ligamentous injuries. In this paper published in the Journal of Orthopedic Trauma, they analyzed 100 patients, and they found that 91% of patients had evidence of lateral meniscus pathology. 77% sustained one or more ligamentous injuries. 68% had posterolateral corner injury. 44% had meniscus tears. Again, we have another study published in the Journal of Knee Surgery in 2010, and they analyzed again 103 patients. They found out 71% having at least associated one ligament torn, 53% multiple ligaments torn, 26% knee dislocation, meniscus tears in 49%, of them lateral in 34%, medial 24%, both in 10%. Is traumatic meniscal lesion associated with acute fracture morphology changes of tibial plateau? This means, can we expect meniscal lesion from the radiological picture and the morphological tibial plateau we have? They found out some radiological criteria associated with meniscal lesions. These are the fragment subsiding this of 8 millimeter in the sagittal CT scan, posterior tibial slope exceeding 11.74 degrees, fragment width of tibial plateau surpassed 3 centimeters, widening more than 3 centimeters in the coronal sections. All these were associated with meniscal lesions. And in this study, they studied the association of tibial plateau fracture morphology with ligament disruption. And they found out that if the grade of the Schatzker classification increases, the likelihood to have medial collateral ligament and posterolateral corner tear is increased. If medial plateau fractures, we have more posterolateral corner tears, and if lateral tibial plateau fractures, we expect to have more medial collateral ligament and ACL tears. And we have a question here. If we have associated knee ligament injuries, do they worsen the tibial plateau fractures outcome? This is a matched cohort analysis, and they came to the conclusion that the presence of a tibial plateau fracture in conjunction with a ligamentous knee injury did not have a negative effect on the post-operative patient-reported outcomes. Another study published in the Journal of Orthopedic Trauma 2018 about the associated soft tissue injuries and their outcome if they are associated with tibial plateau fractures. And they analyzed 60 over 82 patients having associated soft tissue injury when they did MRI examination. It came to the conclusion again that patient-reported outcomes and range of motion assessments were not significantly different in patients with and without meniscal tears and complete medial collateral ligament ruptures. And they raised this issue that preoperative MRI in patients with tibial plateau fractures to diagnose soft tissue injuries may not alter the surgical treatment and will not change the patient prognosis for midterm outcomes. This might answer the question raised also in the distal femoral fractures associated with ligamentous injuries. What about the principles for definitive fixation? First of all, we should plan. And in order to plan, we should understand the fracture by doing the full radiological workup, plain X-rays, CT scan. Then we can classify the fracture. And according to this classification, we will put our surgical plan. The goals are anatomical reduction of the articular surface, regaining the axial alignment and maintaining this axial alignment by stable fixation. This is an example. How can we understand the fracture? If we have the plain X-rays, they will not give us full picture about the fracture. In order to understand the fracture, we should have the CT scans to appreciate where are the split fractures, where are the coronal shear fractures, where are the articular depressions, and then we can classify our fractures. We have classic classifications like the Holland-Moore classification, type 1 coronal split fracture, and this is one of the early classifications highlighting the coronal split fractures found in medial tibial plateau and also in lateral tibial plateau as well. Type 2 entire condylar fracture, type 3 rim avulsion fracture, type 4 rim compression fracture, type 5 4-part fracture. And we have the Schatzker classification. It is the most famous classification, and all of us know this classification. We have partial articular fractures, type 1, the split fracture, type 2, split depression fracture, type 3, the pure depression fracture, and type 4, we have this medial condylar fracture, and we have in type 5 bicondylar fracture, but still the articular surface is connected to the diaphysis. Type 6, we have this bicondylar fracture, and the diaphysis is not more connected to the articular surface, and both types 5 and 6 are complete articular fractures. The AO classification is considered a rearrangement of the Schatzker classification. Type A is extra-articular, type B partial articular. They are Schatzker 1 through 4, type C complete articular, Schatzker 5 and 6. However, these fracture classifications, Schatzker or AO, didn't address the posterior condylar tibial plateau fractures. Although we have some reports about these fractures, an example, this report published in the Journal of Bone and Joint Surgery in 1998, another one published in the Journal of Orthopedic Trauma in 2005. Recently, we have the 3-column classification published by Kongfeng Glu in 2010, and they introduced a new classification based on understanding of the fracture using CT scans as well as the 3D reconstructions. And they developed a 3-column concept to treat the tibial plateau fracture. These 3 columns are the lateral column, the medial column, and the posterior column. This is the first classification to include and highlight the importance of the posterior column. And they put landmarks to define these columns. And they defined the column fracture as breakage of the corresponding cortex. Articular depression with a break of the column wall is defined a fracture of the relevant column. Pure articular depression, Schatzker type 3, is defined as a 0-column fracture. So if we have anterolateral fracture plus separate posterolateral articular depression with a break of the posterior wall, this is defined as 2-column lateral and posterior column fracture, although it is in the Schatzker classification defined as split depression type 2 fracture. The anteromedial fracture with a separate posteromedial fragment is defined as a 2-column medial and posterior column, although in Schatzker it is classified as medial condylar fracture type 4. Articular depression in the posterior column with a break of the posterior wall is considered 1-column. It is a posterior column fracture, which is not included in any type of Schatzker classification. So this is a new way of thinking, and it is correlated to the mechanism of trauma as well. A medial column fracture results from varus and extension injury, lateral column valgus and extension injury, and the posterior column as the result of the flexion injury. What about the reliability of this 3-column classification relative to Schatzker classification? The 3-column classification showed substantial agreement, and it provides a higher agreement among different surgeons and could be popularized, widely practiced in clinical centers. Again, other investigators suggested to have 4 quadrants of the tibial plateau. So they splitted the posterior column into two halves, a posterolateral and posteromedial quadrant. And the medial and lateral columns will be named anteromedial and anterolateral column. This is for severe and complex bicondylar 4-quadrant tibial plateau fractures. And again, they tested the reliability of this classification, and it was proven that it is more inclusive classification for the posteromedial and posterolateral fractures. Schatzker and Mauricio Kafuri revisited the Schatzker classification of tibial plateau again, and they published their modification of the original Schatzker classification by adding some modifiers to the original classification. They divided the tibial plateau into two main halves, anterior and posterior. And if we have one condyle affected, they will add A or P, A for anterior, P for posterior, if we have inclusion of the posterior or the anterior part of the condyle. And this is the equator of the division. It is not exactly in the center, but it is anterior to the head of the fibula and just posterior to the attachment of the superficial medial collateral ligament on the medial side. So they have now two halves, anterior half, posterior half. If we have bicondylar fracture, they again modified the classification by adding AL for anterolateral quadrant, PL for posterolateral quadrant, AM for anteromedial quadrant, PM for posteromedial quadrant. And they add these abbreviations to the Schatzker classification. Frosch and his working group divided the tibial plateau into 10 segment classification. They divided the anterior segment into 5 segments, and the posterior one into another 5 segments. So they have 10 segments in order to understand and appreciate which approach is appropriate for each segment of these anterior and posterior halves. But it may be a more complex one. So we come back again to the 3-column classification of Kong-Feng-Liu, and this is actually the basis of our understanding and thinking and decision making. And he also published his technique through combined approaches, anterolateral and posteromedial approaches. And this is actually a turning point in the decision making for the choice of the approach and fixation technique. And they popularized these two approaches, the anterolateral and posteromedial, and they published the floating position based on lateral position of the patient, so they can turn the patient prone to have the posteromedial approach and then turn the patient back to have the anterolateral approach. We all know the anterolateral approach, the submeniscal exposure of the articular surface of the lateral tibial plateau in order to deal with depressed articular segments. This is a submeniscal arthrotomy that gives us insight inside the joint. And we have also the anterolateral approach exposing this part of the tibial plateau. We can expose the whole anterolateral surface down to the head of the fibula. But we cannot go behind this. We cannot go posterior to this. So we miss the posterior part of the tibial plateau when we go with the classic anterolateral approach. The posteromedial approach is an L-shaped approach posteromedial, and we go in the plane between the pes and sinus and the medial head of gastrocnemius, and we, after elevating the soleus and the popliteus tendon, we can go and we can expose the posterior aspect of the tibial plateau, 2/3 of the posterior aspect of the tibial plateau from medial to lateral. About 70% of the posterior articular surface can be exposed through this exposure, and the medial head of gastrocnemius will protect the neurovascular bundle. So we have only 30% of the articular surface. This is the posterolateral surface that cannot be fully exposed through this approach. However, you can reduce it, put an oblique plate. The proximal part of the plate will buttress the posterolateral part of the articular surface, and it comes obliquely to the wound on the middle side. We cannot put it straight away posterolaterally. This is the posteromedial approach. This is the area of exposure of the posteromedial approach. We still have this blind spot posterolaterally. We cannot access it from the anterolateral approach. We cannot access it fully from the posteromedial approach. Some investigators described medial gastrocnemius head tenotomy in order to enlarge the exposure and to go more laterally. We are all familiar with the medial approach of the tibial plateau in the classic type 4 Schatzker tibial plateau fracture. So we can expose the medial plateau fully from the medial side. We are all familiar with this exposure. So this exposure is different from the posteromedial exposure published by Low or popularized by Low. So we have a picture. Are there 4 tibial plateau columns? We have only a problem with this posterolateral fragment or posterolateral part that cannot be approached from behind and that cannot be approached from the front. This is our main problem, and we will discuss now what are the exposures that can reach this part of the tibial plateau. And some authors returned back again to the 3-column classification, and they can address this blind spot and reduce it indirectly and buttress it by this type of blade with an extension or an arm that lies on the posterolateral part and reduced from the medial side, as we can see here in this diagram. So what are the exposures to the posterolateral fractures, the posterolateral part of the plateau? We have some exposures we will go through quickly. We have the extended or the modified anterolateral approach. We have exposures without osteotomy and exposures with osteotomy. So we can extend the anterolateral approach either without osteotomy or with osteotomy. We have the fresh osteotomy. This is a posterolateral exposure, an extended posterolateral exposure, where you can go through this exposure to deal with the whole lateral tibial plateau. the lateral column and the posterior column from the same approach. And we have the prone posterolateral approach. You can attack only the posterolateral part, the blind spot from other approaches. This the part we are talking about. And these are approaches: the extended anterolateral, the frosh, and the prone posterolateral. What about the modified or extended anterolateral approach? This is the first one without any osteotomies. And this was popularized by JKO from South Korea and his working group. The knee is flexed after having classic anterolateral exposure, and it's flexed right angle to relax the fibular collateral ligament, the lateral collateral ligament, and the common peroneal. Then we work in the interval between the fibular collateral ligament and the posterolateral surface of the lateral tibial plateau, and they named it the parafibular collateral ligament space. Then they put a Hohmann retractor to protect the popliteus tendon and the fibular ligament and the common peroneal nerve. And when we work submeniscal, we can reach posteriorly after putting this Hohmann retractor posteriorly, and you can introduce a pointed reduction clamp posteriorly to reduce the fracture and fix this posterolateral fragment indirectly. We have other extensions using osteotomies. When we review the literature, we have 3 types of osteotomies to extend the classic anterolateral approach. One of them is transfibular approach. This is a popular and famous one. When we do this fibular osteotomy, we can reflect the fibula with the attached collateral ligament and the biceps tendon, so we can expose the posterior part of the lateral tibial plateau safely with protection of the common peroneal nerve. We have another technique. It is Cherner-Johnson extensile approach, where they osteotomize the Gerdes tubercle. Incomplete osteotomy with reflection, hinging the Gerdes tubercle with the iliotibial band attached to it. Then you can go inside the tibial plateau and reduce and elevate the depressed posterior tibial plateau from the lateral side. And lastly, we have lateral femoral epicondylar osteotomy. It is gaining popularity nowadays. One of the approaches of choice for extended lateral and posterolateral approach. So they osteotomize the site of attachment of the lateral collateral ligament, the lateral femoral epicondyle, and reflect the lateral femoral epicondyle with the lateral ligament, so we can have exposure of the popliteus tendon. We protect the common peroneal nerve and get inside the knee from the lateral side and go posterior as much as we can. The last one is the prone direct posterior approach. This is a limited exposure to the posterolateral fragment. It is a direct posterolateral approach. You expose the common peroneal nerve and work between the common peroneal and lateral head of gastrocnemius. And this approach is limited by the perforation of the anterior tibial artery, the site of the perforation. And in this cadaveric study, it perforates the interosseous membrane at nearly 4.5 centimeter distal to the lateral tibial plateau, or 3.5 centimeter distal to the fibular head. So we cannot go far distal more than this, and we cannot put a longer plate more than this. Otherwise, there is high risk of injury of the anterior tibial artery. Approach exposure is a new posterolateral approach without fibular osteotomy, and it is an extensile one. Through this exposure, we can go anteriorly to expose the lateral column, the anterior part of the lateral tibial plateau, and posteriorly to expose the posterolateral fragment. And we can put the plate again in this window we mentioned, limited by the site of perforation of the anterior tibial artery. JKO and his group put the fracture morphology fragment posterolaterally into 4 morphology possibilities. Isolated posterolateral fracture fragment, posterolateral fracture with associated anterolateral plateau fracture, posterolateral fracture with posterior shearing fracture. This means the medial side is posteriorly fractured as well. We have posterior fracture, both medial and lateral, and posterolateral fracture with a bicolumnar plateau fracture. And according to these possibilities, they put this algorithm for treatment. If it is isolated posterolateral fracture, we can go through direct posterolateral approach or a modified anterolateral approach. If it is associated with an anterolateral plateau fracture, then the Frosch exposure is the ideal one, or a modified anterolateral approach. If we have a posterior shearing fracture affecting both medial and lateral, then we will go posteriorly through the posteromedial approach plus minus posterolateral if needed. If we have a bicolumnar, then we should go through anterolateral to address the anterior part of the lateral tibial plateau, posteromedial as mentioned by Lowe in the 3-column classification. Then we may add another approach to the posterolateral fragment. These were all the updates about the classification of tibial plateau and their impact on the surgical exposure and the choice of the surgical approach. I hope we could understand these updates. Now we are going to talk about issues related to fracture fixation and what are the updates as well. We all know that buttress fixation is preferred for column fractures, and the main buttress plate is chosen according to the injury mechanism. The buttress is required for the condylar fixation, but if we have extension, metaphyseal extension, we need a bridging plate exactly figured out by Professor Sofiene in his lecture about the distal femoral fractures. Here we have one of the updates, the rim plating of posterolateral fracture fragments through a modified anterolateral approach. And this Korean group described their technique of contouring a 2.7 millimeter variable angle locking compression plate from the foot set. And the plate is contoured according to the shape of the rim of the plateau. And they go through the extended anterolateral approach, and they reduce the posterolateral fragment and pass this contoured rim plate from anterior to posterior, as shown here in the CT scan, the axial. So the plate will buttress the posterolateral fracture fragment, and they put this in the accessible lateral limb of the plate. This is one of the new techniques published to deal with the difficult posterolateral fragment. One of the debatable issues, single lateral plate or we apply double plating. And we have small number of studies, so we cannot draw a solid conclusion. But the end is, when we have undisplaced medial fragment, we can apply a single lateral locked plate instead of having double plating. This is an example of a simple medial tibial plateau fracture and the complex lateral one with depression, split depression fracture. So we will go from the lateral side, reduce the fracture, fix from lateral to medial. There is no need to go medial and put another plate when we have a simple medial tibial plateau fracture without coronal split, without coronal shear fracture. Coronal shear fracture, then we should put an anti-glide or a buttress plate from the medial side. This is again the compared 48 bicondylar fracture using a single locked plate versus double plate. There is no difference regarding surgical time, union rate or time, the scores, the complications. However, wound size, blood loss are less in the single locked plate, but we have more post-operative malalignment of proximal tibia in the single locked plate, more symptomatic hardware irritation as well. What about this comparative study of single lateral locked plating versus double plating? They included two groups and they found significant incidence of malalignment in the single lateral plating group, more soft tissue issues with the double plating groups, but no significant difference in the functional outcome. So if we apply a single locked plate, the other side should be a simple one, and we expect to have axial malalignment if we are not aware about this. Again, we have a debate about locking versus non-locking in young aged active patients, I mean with good quality of bone. And this paper is published in the Journal of Orthopedic Trauma just 4.5 years ago. And they came to the conclusion there are no differences with respect to demographics, injury characteristics, radiographic outcomes, clinical outcomes between the locking plate and the conventional plates. And they concluded implant costs were significantly greater in the locking group compared to the non-locking group. So non-locking group offers less cost. There is no difference. This is the opinion of the investigators. It is still a debatable issue. What about the use of a rafting screw in depressed fractures without putting bone graft? Is it a valid technique or not? There are increasing reports about the success of this technique. This is one of the reports. They used the rafting screws in 38 tibial plateau fractures with split depression, and they concluded that fixation using a peri-articular raft construct through a locking plate without the use of a bone graft or bone substitute for split depression proximal tibial plateau fractures is a viable option. This is one of the tricks published about rafting K-wires inside out. We always have this problem. When we elevate the depressed segment of the tibial plateau, through working through the window of the split part of the fracture inside and elevating the depressed fragment, when we put the wall back or the split part back, we are not sure that we are still keeping the reduction achieved. So they published this technique to put K wires inside while the door is still open. The split part is still open. So you can see the quality of reduction and maintain it by inserting multiple K wires from lateral to medial. Take them from the medial side out. Make sure that you are still supported by the K wires. Then return the door back, close the door back, return the split part back, and return the K wires again from the medial to the lateral side. Penetrate the wall and cut them, bend them on the lateral side while you are confirming the reduction of the fragments by the rafting K wires, and then you can put your plate construct on the lateral side. One of the issues as well, how can we fill the defects? Bone grafts or bone substitutes? And this paper included 120 tibial plateau fractures, and they used iliac crest grafts in 38 patients, calcium phosphate bioabsorbable cement in 82 patients, and they found no difference in union rates and time. However, they found significantly higher rate of articular subsidence in the bone graft group, and they came to the conclusion that the bioresorbable calcium phosphate cement is better in terms of prevention of subsidence. What about the use of ring fixator in tibial plateau fractures? And if we compare the results of the ring fixator to open reduction and internal fixation, can we find differences in complex types like type 5 and type 6 fractures? This paper included 137 patients, 68 patients in the ORIF group, 69 patients in the Elizarov group, and they found no differences in clinical, functional, and radiological outcomes. What do you think about this? It is the matter of principles. Achieving anatomical reduction of the articular surface and good fixation, restoration, axial alignment is the key. And they came to the conclusion that no single treatment option can be applied in all cases. The decision depends on the complexity of the injury, surgeon's experience, and host factors. We published our experience in high energy T-plateau fractures by applying the Elizarov external fixator, and we found excellent results in 16.7% of cases, good in 60%, fair in 20%, and poor in 3.3%. But all patients were high energy trauma, including soft tissue injury. 10 of them were open fractures. Our take-home messages. Fully understanding the fracture is essential for decision-making and definitive fixation. Approach selection and fixation should take into account the soft tissue injury associated with the tibial plateau fracture, the mechanism of injury, and the 3D morphology of the fracture. We should this 3D vision when we assess tibial plateau fractures. The 3-column classification provides a 3D way of thinking for the treatment of tibial plateau fractures. to summarize our surgical approaches according to 3-column concept, we have the anterolateral approach for the lateral column fracture. We have the medial approach for the medial column fracture, and we have the posteromedial approach in the prone position for the posterior column. It can give exposure to about 70% of the posterior column from medial to lateral. And we have this difficult part, the posterolateral part. We have many options: the extended anterolateral, the modified posterolateral after Frosch, and the direct posterolateral in prone position, the extended anterolateral either without osteotomy or with osteotomies. The osteotomies we have maybe osteotomy of the fibular head, osteotomy of the Gerdes tubercle, and nowadays osteotomy of the medial epicondyle of the femur at the site of the attachment collateral ligament. This approach is gaining popularity nowadays. Thank you very much for your attention.
Thank you so much, Professor أسامة، على المحاضرة الشاملة الجامعة الأكثر من رائعة دي يا فندم. كم وزخم من المعلومات بصراحة يعني فوق الوصف يا أستاذ، ودي دايما شيء من العظماء يعني.
لا العفو يا فندم، العفو. احنا
ربنا يخليك يا دكتور أسامة بيه، وربنا ينفعنا بعلم حضرتك دايما يا دكتور أسامة بيه.
اللي بنتعلمه للزملاء جميعا.
ربنا يدي لحضرتك الصحة يا فندم، ربنا يجعله ميزان حسنات حضرتك كده يا فندم.
بشكر حضرتك لإتاحة الفرصة.
العفو يا فندم، ده شرف كبير لنا، احنا اللي بنشكر حضرتك على وجود حضرتك معانا النهارده يا استاذنا.
الله يبارك في حضرتك، الله يبارك.
I think we have lots of questions, Professor أسامة.
إن شاء الله نشوفهم يا فندم.
هو في سعادتك هو في سؤال من القديم للدكتور سفيان بيه، فهل سعادتك تحب نجاوبه؟
أنهي السؤال؟
Did you make a total knee replacement in complex fracture في ال distal femoral fractures?
Yes. I think this is one of the options in severely osteoporotic fractures beyond surgical reduction and fixation. It is not a routine practice, but it should be a solution for few cases that are not amenable for open reduction and internal fixation.
Yes, sir. هو بعض الإخوة من الجزائر طالبين رقم الواتساب لسعادتك أو إيميل لحضرتك يا فندم.
أهلا وسهلا.
لو ما عليك مشكورا نبقى نكتبه يا فندم على ال.
هبعته حاضر.
شكرا يا أستاذ. Another question, sir. Is it possible to use arthroscopy to treat meniscal tear in the presence of type 3 or 4 plateau?
Yes, the role of arthroscopy in tibial plateau fractures is present to check the quality of production in depressed articular fractures and to deal with meniscal lesions. And nowadays there is a term fractoscope. So we have gaining now some papers about the combining the arthroscopy with articular fracture treatment in tibial plateau. We have concerns in complex cases about the compartment syndrome after arthroscopy, but in simple cases you can use the scope. We have questions about what is the sensitive.
Yeah, problem? What's your experience with the sensitive problem when we use the double approach? How can you avoid it?
I think you mean the soft tissue problem?
Yes, I think so.
Yes. First of all, we should address this issue, the soft tissue condition, and we will not go to surgery unless there is soft tissue resolution, the soft tissue action subsides, then we go for surgery. and with anterolateral posteromedial approaches, you have enough skin bridges between the two approaches. They are not close to each other like in the past when the surgeons used to use the anterolateral and medial exposure directly. So the skin bridge in between was a narrow one, and then they got many soft tissue complications. By using the posteromedial exposure, we have enough bridge.
Yes, sir. Your experience, sir, with the rim plate?
I don't have experience with this rim plate. It is published by JKO from South Korea and his working group. I like to just transmit as one of the new techniques.
Yes, sir. Another question, sir, from Dr. Muhammad Sultan. Any available studies or your expert opinion regarding the posterolateral fracture associated with medial collateral ligament injuries or cruciate ligaments and the need to repair it accurately with the fixation, sir?
As we mentioned in the published data about the associated ligamentous injury with tibial plateau, they give priority to the bony stabilization first, then they address the issue of ligamentous injury. And I think this may change in the coming years as we have more and more incidents of associated meniscal and ligamentous injuries. And I expect in the coming decade to have an algorithm, especially in multi-ligamentous injuries, and especially if the tibial fracture is associated with dislocation of the knee. So we may have an algorithm about which ligaments to reconstruct with the internal fixation and which postpone to be later on addressed after fracture healing.
Yes, sir. Another question, sir, from Professor Muhammad Abdelal. Your comment on prophylactic high tibial osteotomy in rim fracture.
I don't understand the question, Dr.
Yes.
Muhammad.
Yes.
Do you mean in rim compression fracture according to Moore's classification? I think so.
I think so, sir.
In rim classification, in rim compression fracture on the medial side, you may deal with them like the medial wedge open osteotomy in terms of grafting any defects after reducing the fracture and regaining the axial malalignment, because the rim compression fracture will drift the tibia into varus. So if you reduce these fractures, you will be left with a defect. So you should address this issue by graft and angular stable plates medially. Lock
Yes.
the plate medially.
Yes, sir. We have another question from Dr. Ghassan. Dear Master, dear Sir, I'm sorry, sir, I have lost the questions. Dear Master, you have spoken of all the approaches that depend on the type of fracture and the effect of columns, but currently there are many articles that talk about the balloon tibioplasty and the arthroscopy-assisted surgery. My question is, are there techniques available, and what are their results, sir? And if you have any experience with these techniques, sir?
Yes, we have some publications about the balloon tibioplasty and arthroscopy-assisted surgery. I didn't include them in the lecture because we need validation, more validation of the techniques, and at the same time, we see what we can do rather than what is not available in our hospitals. So if later on the arthroscopy-assisted surgery becomes validated, it will be a routine in our practice. It is validated in pure depression types in order to check the quality of articular reduction, and you can insert the rafting screws percutaneously. You can work with a window to elevate the depressed fragment. You don't have the concern about the leak of the fluid inside. So working with the arthroscope is gaining more and more popularity and playing more and more role in dealing with meniscal injuries associated with tibial plateau fractures, but we still need more information about this.
Another question, sir, are there specific indications for MRI?
Yes, there are specific indications for MRI. We mentioned from the plain X-ray, there are some morphologic types that you suspect associated meniscal and ligamentous injuries. For documentation, before putting the implants inside, you may do MRI examination of these fractures to document the associated ligamentous injuries. And if there is a primary role for dealing with meniscal injuries, either through open approach or through the scope.
Yes, sir. We have another question, and I think you have answered it in your presentation, sir. Your personal choice approach for posterior lateral column fracture fixation, and any tips and tricks and any differences in the management of contained and non-contained rim fracture. I think you have spoken about this, sir.
Yes, we have many possibilities about this posterolateral column fracture, whether it is pure posterolateral or associated with injury, and we put this algorithm published by the group of GKO.
Yes, sir. Another question from Dr. Muhammad Riyad. If there are multi-ligamentous injury with the fracture, what's the consequences of repair and fixation?
This is one of the big issues in tibial plateau fractures. If the knee joint is dislocated, the first priority will be to relocate the knee joint to anatomically reduce the knee joint, and in the acute stage, you reduce the knee joint anatomically and fix with an external fixator till you complete your full workup, and you decide the surgical approaches and fixation. Then you will come to the ligamentous reconstructions. However, you may do primarily some of these ligamentous reconstructions, especially the collaterals, if they are part of your surgical exposure to the fracture.
Yes, sir. سؤال من اخونا العزيز دكتور باسم. عند استخدام الفراكشر لاين كم يجب ان يكون عدد الثقوب تحت نهايه الباترس? How can you choose the proper length of the plate?
You have two important points when you choose the plate. The length of the plate, the working length of the plate, the lever arm, and the number of screws. And this depends on the fracture zone, whether it is a simple fracture or a multi-fragmentary fracture, and whether the plate is a locked plate or a standard plate. So if it is a multi-fragmentary fracture, you have the plate divided into 3 zones: proximal, middle, and distal, and the fracture zone in the middle. So you should span this fracture zone, and at least you have 3 locked screws in the diaphysis and more in the metaphyseal area, because the perches in the diaphysis differs from that in the metaphyseal area. So it depends on the fracture morphology, but you should expand the fracture sufficiently by the length of the plate rather than only the number of the screws. And one point was also shown in the lecture of Professor Sofiene. The plate should be centered over the bone, especially the locked place, because if it is eccentric in relation to the shaft, you will not get the proper length of the screw inside the bone. You will have shorter screws. So this will affect the stability of the construct as well.
عذرا دكتور Sabi, we have more questions if your time allows us.
Inshallah.
What approaches can be used simultaneously safely, sir? سؤال دكتور محمد رياض.
What
approaches can be used simultaneously, safely?
The anterolateral and posteromedial approaches in the floppy lateral position. So you can have the patient prone for the posteromedial, then turn the patient on his back again for the anterolateral. So you can do them on the same session.
Yes, sir. The role of femoral distraction assisted reduction, sir.
This is a very good question. The femoral distractor is used in each articular fracture for indirect reduction. In tibial plateau fracture, it has crucial role in some situations. One of them is type 4 tibial plateau fractures, the medial condylar fracture. If we have femoral displacement, like we have shown in the CT scan as one of the radiologic predictors of compartment syndrome. If you have this femoral displacement and side-to-side displacement between the femur and the tibia, it is a type of fracture dislocation of the knee joint, and it is 100% associated with ligamentous injuries as well as meniscal injuries. So one of the techniques to reduce the joint again is femoral distractor use. The femoral distractor will distract the joint and helps to realign the knee joint again. Another one, the posterolateral fracture. If you are going to expose it through one of the extended anterolateral exposures, after having submeniscal exposure, the use of the femoral distractor will open the way so you can see the posterior aspect, and you can put your pointed reduction clamp and reduce it guided by the C-arm. So the femoral distractor is useful all the time.
Yes, sir.
But be aware about the amount of distraction and flex the knee to relax the common peroneal nerve when we use it on the lateral side to protect the common peroneal nerve.
What kind of plate, sir, do you recommend in posteromedial column fixation?
In posteromedial, use the small set T plate. It will offer a very good buttressing and a low profile plate. It will work very well to buttress the posterior column of the tibial plateau posteromedially, and it is not a bulky one, especially if you will need again to put a medial plate if you have a complex fracture. So it will not hinder the application of screws through the medial plate as well. Small T locked plate.
Sir.
Otherwise, you can use small DCP. It is according to the fragment of the articular fragment. You can buttress it by a T or adjust a small DCP.
Yes, sir. Dr. Muhammad Sultan, sir, is stating that I have experience with using LS distal radial locked plate for buttressing using the posterolateral or posteromedial rim fracture. Do you use or you recommend this technique, sir?
It is one of the options. Yes, it is one of the options.
Yes.
Very good.
Another question, sir. Do you fix the medial or lateral plate first?
This is again good question.
Yes.
This depends on the fracture. Which fracture is more simple and will give you more guidance about the restoration of the articular surface. Again, it was mentioned by Professor Sofiene. How can you convert type C into type B? How to make your life more easy or easier during surgery? I would prefer to expose both condyles at the same time, to open the lateral and medial at the same time, to work with the articular depressions, to elevate them, to have the nice articular reduction before achieving any fixation. Then fix the simpler one and proceed to the other one. But you have both exposures at the same time if you are going to have the same position of the patient. I mean, the supine position. But if you are going to alternate, this is a different issue. Yes. Then you will start with the simpler one.
Yes. The last question, sir. Is it possible to do a submeniscal arthrotomy by the posteromedial and posterolateral approaches?
Usually, you can reduce them by going through the fracture itself, elevating it, returning the fracture back to its place, fixing preliminary K-wires, and putting the buttress plate from behind. In most cases, you can achieve anatomic reduction by doing this maneuver. Always elevate the fracture more than the feeling you have, because we have the feeling that is okay, but usually it is still undercorrected. So have the feeling that you are overcorrected in order to have it in place. And all the time you check the reduction by the C-arm. Going submeniscal from behind is sometimes impossible.
شكرا جزيلا استاذنا الفاضل استاذ دكتور اسامه بيه فاروق. يعني الهول مارك اوف AO in Egypt and the Middle East. احنا طبعا يعني يعجز اللسان عن شكر حضرتك يا دكتور اسامه بيه على المجهود والكم المعلومات الجميل اللي احنا شفناها النهارده.
لا العفو يا دكتور محمد بيه، يا سياده العميد. احنا يعني نسعد الوجود مع حضرتك في كل الميتنجز الجميله، وربنا يوفق حضرتك وربنا يتقبل من حضرتك المجهود الضخم ده. ويعني الحقيقه الاستمرار 3 سنوات ده انجاز، ويعني هو علم ينتفع به، وان شاء الله يكون في ميزان حسنات حضرتك.
اللهم امين يا رب، اللهم امين. جزاكم الله كل خير يا استاذنا. احنا في نهايه اليوم الاكثر من رائع ده بنشكر اساتذتنا الافاضل بروفيسور سفيان القلال من تونس، واستاذنا الجميل استاذ دكتور اسامه بيه فاروق، القيمه والقامه من مصر. يعني الحمد لله. وطبعا بشكر كل اخواتنا الحاضرين من مصر ومن الجزائر ومن تونس ومن ليبيا ومن سوريا انا شايف، ومن التشيك ومن انجلترا. طبعا يعني يوم اكثر من رائع بصراحه. ان شاء الله موعدنا مع حضراتكم هيستمر الجمعه الجايه مع العالم الجليل، مع القيمه والقامه استاذنا الكبير استاذ دكتور محمد اسامه حجازي. دكتور اسامه حجازي will speak about common pediatric hip problems. طبعا استاذنا الدكتور اسامه بيه يعني غني عن التعريف يعني. فطبعا يعني الحمد لله يعني بفضل الله ثم بمشاركه الاساتذه الافاضل معانا